Please welcome Michael Whalen. Thank you.
Well, good morning, everyone. Just give me a second here to go live with the projector here, and we'll be ready to go. That was easy. Can you hear me okay in the back? Great, excellent. Well, thanks. The Kalahari Resort, how about this? It's not the Pocono Manor, but it'll do. As Albert said, I'm Michael Whalen, and this is going to be a different kind of lecture. I hope you enjoy it. We're going to do things a little bit differently. First, we're going to discuss some things that you have to remember. You're not here to diagnose, and you don't diagnose in the field, but I find it's important that if you're dealing with a strange medical modality, that in the long run you kind of think, well, maybe it's this, maybe it's that. If anything, you can impress a doc, maybe even impress a nurse. I know that's hard to do because I used to be one. So what we're going to do today is just talk about some different diseases that you may or may not ever run into in the field, but we're going to make it a little more interesting on how we decide what this disease might be. So what we're going to do is show you a slide, and I'm going to read you some symptomology and some hints of what the person has been doing or what they did. And if you think you know what the disease might be, shout it on out. The good news is, if you're wrong, it don't matter because we don't diagnose, right? If you're right, everybody's going to say, man, that's the smartest guy in the room, isn't it? But what I am going to ask you, because every now and then we get somebody that knows everything, and if you get more than 2 right, we're going to ask you not to guess anymore or tell your partner because we don't want one person to drive everything. We're going to hit about 15 diseases, depends how things go. Some of them are diseases you may have even heard of. Some of them are diseases that you never really thought of. And then there's probably a couple that you just never did hear of and may or may not ever see. So when I was the EMS liaison at St. Joe's, one thing I really like to do is follow up on patients that weren't the typical abdominal pain, weren't the typical STEMI or stroke, and let the EMS providers know what the disease is. And if you see one thyroid storm in your life, it's kind of good that you know that's what it was. So if you are an EMS liaison and you're in a room, that's kind of important to follow up with our EMS providers, what some of these weird diseases were. If you're an EMS provider, don't be afraid to reach out to EMS liaisons and say, hey, can you follow up on this patient? Let me know what it was, because it's kind of just neat when you get weird stuff like that. If anything else, then you can come up and do this lecture in a couple years and I don't have to. So, name the disease. There's a factory worker who unloads turkeys at a processing plant. And I know in our region, we have pretty many live turkey and poultry plants. He's complaining of flu-like symptoms, mild respiratory distress, and slight chest pain. So what are you thinking right away? Flu, yeah. Avian flu, right. So are we going to treat that differently than regular influenza? No, we're not. So does the diagnosis really matter? Not too much. Does the treatment matter? Not yet. But it is what it is what it is. Most biologicals start out with the same symptoms, flu-like symptoms. So let's see what this guy might have. He's got parrot fever or chlamydiosis, not chlamydia. Chlamydia is something different. We're not picking up any chlamydia over this week. We're staying clean, we're staying healthy, but chlamydiosis. And what it is a bacterial infection that's carried by parrots, chickens, turkeys, pigeons, cockatiels, parakeets, and ducks. And what happens? These bacterial infections get into our poultry or our avian population, and then by direct contact, be careful with this, you don't want to tell people that you had parrot fever because they're going to ask you how you got it. You could end up with these symptoms, which are flu-like symptoms. Transmitted by secretions, so if you and your bird were sharing spit, bites from the bird, or kissing. Now you say, well, who's going to kiss a turkey? I got to tell you, I've seen people, you're a turkey kisser? That's okay. You have chickens, and you kiss your chickens. So remember, if you end up with chlamydiosis, you want to make sure when you tell your friends that, say, not chlamydia, chlamydiosis, because then, it is what it is. So it's very transmissible. So keep that in mind if you think it's cute to kiss her chicken, or you see a parrot and he wants to give you a kiss, that you could actually get sick. Yes?
Okay, so you have your chickens and you're kissing your chickens, and they don't go anywhere else. Could they be infected, or is it wind transit from the
If you had your chickens from egg, you're probably safe. But if they go to parties or up to the MS conference, and we're having a little bit of a party tomorrow night at the indoor water park, watch your chickens then, because they could come home with parrot fever or chlamydiosis, not chlamydia. Your chickens won't get a venereal disease. But some of these ongoing symptoms, so like most bacterial, starts out with just flu-like symptoms, will progress with nausea, vomiting, muscle and joint pain, diarrhea, weakness, fatigue, cough, and a dry cough usually, into significant chest pain, some shortness of breath, and photophobia, where lights bother their eyes. So again, if you roll into a chicken kisser and they have flu-like symptoms that now like the lights are bothering their eyes and they have chest pain and shortness of breath, that doesn't look like typical STEMI stuff. You might want to impress your command physician and say, I think this guy might have parrot fever. And they'll be like, why do you think that? You say, I don't know, some little dude told me, and there was a chicken kisser up front. We just thought it was kind of cool. But just like with most things, it's treated with tetracycline or doxycycline, a one-course dose of oral antibiotics, and can be fine. But look at that bottom bullet point. You have flu-like symptoms and you're a chicken kisser, or you load turkeys at the turkey plant, and you're like, well, I just had the flu. I'm not going to the doctor for the flu. I don't really need antibiotics for the flu. And you miss parrot fever or chlamydiosis, you could end up dead. And I don't know about you, but that's usually not my desired thing. Next one. 8-year-old complaining of weakness, sore throat, and swollen glands. Developed a gray, thick, matted material on his nose, mouth, and throat 2 days ago, and that's called a pseudo membrane. When you look in their oral pharynx, you just see this gray gook, just like pasted over everything. And you can see the swelling in his neck there. What are you thinking here? What do we have? Mumps, okay, maybe. Anybody else? Sorry? Tonsillitis? We usually don't see one-sided swelling with tonsillitis, but it's a good guess. It's diphtheria. Who here has ever heard of diphtheria? How do we prevent diphtheria? Vaccine. What kind of vaccine? A tetanus shot. Tetanus and diphtheria, a TD shot. So what we're seeing over the past 10 to 20 years, less and less people are getting standard vaccines. And there's two reasons why we're not seeing that. One is some thought processes that these chemicals can cause other diseases. And the other is affordable health care, that some folks just don't want to spend the $20 to get a tetanus shot. So we can see more diphtheria, and it's kind of a really scary phenomena, a bacterial infection again, and it's transmitted by respiratory droplets. So what do we know if we have this person with a pseudo membrane and a fever and some breathing problems, respiratory droplets? They should be wearing a surgical mask or a procedure mask, and so should you. And I don't know if you guys paid attention, but exactly a year ago now, there was a disease that everybody was talking about, Ebola, that's it. I kind of forgot about it already. But we really had a good opportunity there to talk a little bit more about protecting you as you drive patients in your incubator to the hospital. So Ebola went away, or never came. It depends whose opinion you listen to. And we kind of just stopped thinking about respiratory protection again. So protect yourself, because you can get diphtheria with droplet transmission in the back of your truck. So think about that. If your patient has respiratory symptoms, get them in a surgical mask or a procedure mask. Never an N95 on a patient, and also on you, because it can save your life. So anyway, with the pseudomembrane, fever, diphtheria, they can be treated with antibiotics. And then the CDC in Atlanta actually has an antidote called DAT, or diphtheria antitoxin. You just don't call them up and say, hey, I'm flying my helicopter down and give me a bunch of this stuff. You have to go through a pretty significant request pattern through the DOH and things like that to get the DAT, but it is out there. Fatality rate is about 10%, which isn't that bad for diphtheria, but higher for infants, and we're calling them older people now, people over the age of 40. I know, don't shoot the messenger. But there is some really good information on diphtheria on the CDC website. And if you want this slide deck, I usually don't share my slides because I spend a lot of time making them. But if you want this slide deck, just send me an email. We have a full-page ad in the conference brochure, or I can just give you my card. We'll send you this in PDF format if you want to play with it a little bit, because it's a pretty exciting lecture. So again, here's that swollen neck, and then that's a pseudomembrane. That's kind of pretty stuff, isn't it? And I don't know about you, but if I was transporting someone with respiratory symptoms and that kind of gook in their mouth, one of us or both of us would be wearing a mask, don't you think? So that's that pseudomembrane. It's just a layer of gray gook, and it's really, really nasty. Diphtheria. Okay, we have a hiker. Hikes a lot, not just a guy that walked like from here to the registration desk for the hotel. That's not a hike, that's a stroll. So a hiker, fever, headache, abdominal pain, vomiting, and muscle pain were the onsets of symptoms. So right away, I'm not thinking too much. Maybe the guy just walked too hard and he's dehydrated. But then he got this kind of weird, bizarre little rash about 2 days after the onset of fever. So let's say that this was here, or the person was hiking somewhere else and came here. Any thoughts about this? Who said it? Over here, somebody. What did you say? Rocky Mountain spotted fever. Yeah, good deal, good deal. That's all right. That's all right. You get one more answer and then you're done. So Rocky Mountain spotted fever. We don't see Rocky Mountain spotted fever too often in this area, but when I was in high school, which was 3 years ago, 4 now, who laughed? Oh, you're done. One of my classmates actually vacationed in Colorado and came back with Rocky Mountain spotted fever, and she was actually severely ill for months, and her recovery was almost a year. So Rocky Mountain spotted fever has this really bizarre looking little red spotted rash. Again, not much we're going to do in transport other than treat symptomology, but if you say, this guy's a hiker, he's been outside a whole lot, he's got these red rash on here and the typical symptoms with the abdominal pain and fever, chills and all that, I think he has Rocky Mountain. You get a bonus prize. How do you get Rocky Mountain? Does anyone know? Ticks, yeah. So it's a vector-borne illness, so tick is the way that it's transmitted. What else do we see often with ticks? Lyme disease, known called Lyme because it was first discovered in Lyme, Connecticut. And again, we're all pretty good with Lyme, but the thing that we don't think about is the back end of Lyme disease, where you have those rheumatoid symptoms. So if Lyme's untreated with oral antibiotics, then they start to get the achy joints and mobility disorders and very, very tired. They can actually progress into some cardiac things. So Lyme's not on the slide, but that's something to think about too with Lyme. But we get that nice bullseye rash with Lyme, which makes it a little bit easier to diagnose. So RMFSF, Rocky Mountain spotted fever, or rickettsia, you already knew that it's transmitted by ticks. Signs and symptoms, 5 to 19 days after the bite. Remember, it starts out with flu-like symptoms and then progresses to the rash. Again, treated with antibiotics, treat other symptoms. Can be fatal if not treated within the first few days of the rash. So if you're hiking, you get bit by a tick and you think you have Lyme disease and you don't want to get it treated and you have this rash, get treated because you could be dead in 2 days, and that's never good. Okay, 67-year-old retired sailor from a long-term care facility. You get called because he has poor muscle coordination. His left leg slowly became paralyzed over the past few days. He's noticing some significant loss of his vision over the past week or two and progressive dementia. So is that something that, that would get an EMS dispatch right away? Who said that? Oh my, what was your key indicator for syphilis?
The sores.
Yeah. I was on the fence with that, but my uncle's retired Navy, and I asked him if it would be okay, and he's like, yeah, it's not like that anymore. We're well behaved and we're protected. But yeah. So again, his past medical history, an unusual rash on his hands and feet many, many years ago, and untreated sores on his penis 40 years ago. Now that's a past medical history that I probably would first say, yeah, who cares? Sore on your penis 40 years ago, you don't even know her name anymore. But that's the thing with syphilis. This latent period can be 40 to 60 years post-exposure. So when we talk about protection and personal protective equipment, some diseases last a really, really long time. So again, syphilis is bacteria, secretions biting and kissing, just like our chlamydiosis, but this is different. We're doing it with humans, not with poultry. And initially, shall you be exposed to syphilis, your first primary stage will begin in about 20 days after exposure, so a significant period of time, which makes epidemiological studies a little tough. If you're a robust, unprotected individual, you could have more than one partner in 20 days, which makes everybody being treated and being examined. Usually starts with a painless lesion at the affected area, so oral, anal, genitalia kind of things. That lesion lasts 3 to 6 weeks and will heal whether it's treated or not. So that's what happens with a lot of folks with syphilis. You get back on the ship, you don't want to tell your boss on the ship that you might have picked something up while you're in port. You just let it go. Those symptoms are going to go away on their own. If you make it to the hospital and you get treated, 2.4 million of penicillin G. I used to work as an ER nurse, and we used to give a lot of penicillin G. It's a big, white, milky syringe full of penicillin, and it gets in the butt, and it really hurts. I never had it. They express that it really hurts. So that's the initial stage is about 20 days after exposure. And then long term, if left untreated, really affects the entire body, especially nervous system. So we can see a progression of dementia. We can see nervous disorders, whether it's twitching or weakness, loss of vision, some heart, blood vessel, liver, bone, and joint diseases, and in extreme cases, very uncoordinated muscle movement that this person's actually non-ambulatory, up to paralysis. Even mental illness, we can see some dementia or even some other mental illnesses manifested by syphilis. So, we hear people say, I don't have to really worry about a venereal disease. All I have to do is take some oral antibiotics and I'll be fine. This is lifelong, and it's not a good thing. Secondary lesions, or lesions come back in the mouth, vaginal or rectal area, wherever you're infected, and then can show up many, many times, and it's not a good thing. And then progress into a reddish-brown spot. Other symptoms, swollen lymph glands, fever, and it just goes on and on. Patchy hair loss, headaches, so a lot of stuff. And I'm not going to read the entire slide because I'm not a slide reader kind of educator, but really needs to be treated or it's lifelong. So here's some pictures of some syphilis long-term, short-term lesions, and again, how he ended up with it on his forehead, I'm not asking, I don't want to know, but you can see significant stuff. Now on the back, that's that latent stage where the lesions are just popping up everywhere. He didn't get infected on his back. So again, the fellow with the mustache, I don't know that I'd say, ooh, that must be syphilis, even with a history of something going on. So two that picked up syphilis right away, congratulations. New one, child with cold-like symptoms and a mild cough. Again, how most stuff starts out. After about 2 weeks, the coughing became more severe. On examination, you see this guy, and he actually has some periods of apnea, resolving on its own. He didn't need any respiratory support. But then you notice some violent and rapid coughing, and it's kind of like. So he coughed a lot. I didn't practice that. I hope I did okay. So no trauma, and we know because the instructor told you that he does not have a foreign body in his airway. So what are we thinking? It's just part of something else. So who said it? Where was that? Who said it? Excellent. I can't see you got a big light there. Good. What's another name for pertussis? Cool. And we had a pretty big outbreak recently, right? So yeah. So the Chinese Little League team brought it over to Williamsport, and then it kind of got spread out from there. Yeah. So someone asked about the ecchymosis, the periorbital ecchymosis. It was just a red herring. And I don't know if you ever noticed, but sometimes people have two things going on at the same time. He had too much makeup on, I don't know. So what do you think, just looking at this guy, rapid intervention? You think with assessment, he looks healthy or unhealthy? Yeah. Would you say, we'll just hang out for a little while and talk to the parents and see what's going on? Now, I'd probably want to get him moving as quickly as possible. So here's how pertussis or whooping cough progresses. That first stage, 1 to 2 weeks, basically regular flu-like symptoms. That's when he's the most contagious. That's when we're really spreading the load. So every time he exhales, we're getting some diphtheria into the air. Pertussis into the air. The second stage, the paroxysmal stage, is about 1 to 6 weeks. Could go as long as 10 weeks. Now he has that rapid coughing, and that whoop, how it got its name is they cough so hard they're actually out of air, and when they go, try to suck in that air again, that's the whooping cough. And that's the big stage, and that's when, if they didn't get diagnosed with the flu-like symptoms, that's when they're usually going to get diagnosed, see a clinician, summon EMS, or go to the ED. And then after that, they'll have about 2 to 3 weeks where they're convalescing, but right now their immunity is very, very low, and they can pick up secondary respiratory illnesses. So if you think about it, we put someone with pertussis into a pediatric unit, and there's other kids there with influenza and other things, we can actually be concerned about this child needing reverse isolation, that we're actually being really careful what we get him exposed to. So it's a pretty significant disease. Again, treated with antibiotics and supportive care. We're going to treat the symptoms, and about 2% of hospitalized infants will die. So it's a fairly low mortality rate, but the convalescent period, this child will be under direct medical supervision for up to 2 months, a long period of time. Okay, we got a new one. 36-year-old vegan, so someone that eats no meat? I don't know. They're not from Berks County, that's for sure. Flu-like symptoms a few days ago. nothing really big. But this vegan is very holistic and controlled their fever that they had with a herbal supplement that they bought at a regular herbal supplement store, and it was called Willow Bark. And it seemed like this was controlling the fever. The person was taking the Willow Bark every 4 hours, and their fever would go down, and they'd feel better. But after 4 hours, they had to take more Willow Bark. So they had about a 3-day period of using their Willow Bark exactly as prescribed on the supplement bottle. But now this adult is constantly vomiting and showing signs of lethargy. It was noted that they also had weakness in all their extremities, and during transport, they became completely unresponsive and developed some seizure activity. You do?
Well, is this the one where they wrote the book about the guy?
I don't know.
All right, we'll find out.
In the back.
Is Willow Bark interacting with some other drug they're taking?
It is not. And that's your key indicator, the Willow Bark. If you knew what drug was produced by Willow Bark, by our pharmaceutical companies, yes? Aspirin is made from Willow Bark. So Willow Bark is actually ASA or aspirin. So what kind of disease could be caused by Rye? Who said it? Yes, Rye syndrome. Oh, whoa, wait a minute. So what's the problem with him being 36? It's what? Usually kids, and that's why this is probably one of the most important slides we have today. That's why I wanted to bring this one up, because it's usually in kids and he's an adult. We kind of forgot all about Rye syndrome. It's not a disease, it's a syndrome, because good education don't give your kids aspirin. But adults can acquire Rye syndrome, so it's a very, very important slide. Someone who's taking aspirin for cold-like symptoms or Willow Bark is a herbal supplement that's actually aspirin, and the vomiting and lethargy is the big thing. But again, I don't know if you ever saw me with the flu. I got lethargy. I am bad. I'm ready for ICU. And sometimes I vomit when I have the flu. So again, well, this guy must have Rye's. But once we see that muscle weakness that's more than someone with the flu and the seizure activity, then we really start thinking Rye's. And it's not good. It's definitely not good. And luckily, we educated the public about children and aspirin, and we don't see many kids with Rye anymore, and that's good. Treated.
Can I ask you a question? Is it too much aspirin or just aspirin?
No, it's not too much aspirin. It's just, I guess we call it an untoward effect of the aspirin. Your body doesn't like the aspirin. And that doesn't mean you have an aspirin allergy. That doesn't mean you're going to have Rye's every time you take aspirin. It's just you had a really unlucky experience. So we treat it with glucose, electrolytes, diuretics, because they can actually develop some intracranial swelling, and that's what causes the seizure activity. So these folks are sick, and they really need to get to the ED as soon as possible. We can see mortality within 3 or 4 days, so they really need to be treated, especially for the intracranial swelling. So good neuro assessment on anybody that you think has Rye's. Ready for the next one? 18-year-old, normal state of health, fever and sore throat a week ago. So we can name 6 diseases or syndromes it could be already, right? Yeah, it's good to do this lecture right before flu season. Rapid onset of respiratory distress and drooling. And he must lean forward to breathe. Who said it? Excellent. Was that your second one? All right, you're done. You're out of play now. Congratulations. So what was your key? The drooling or the leaning forward? Or both? Has anyone here seen true epiglottitis? You see it once, you don't forget, do you? Scary, scary, scary. So we'll show you a picture. So with epiglottitis, shallow tachypnea. So they're not breathing deep, but they're breathing fast. So the panting. You'll hear some stridor because we're losing our airway. Often retractions, difficulty or unable to speak. It depends how far along in their epiglottitis or if they're still rule out epiglottitis. But their chest will be clear because this is not a lung disease. This is an airway. Usually there's no history of respiratory disorders, so like no asthma or anything like that, no croup or RSV, and usually no environmental exposures to trigger the epiglottitis. This is the typical epiglottitis patient. Mouth is open, eyes are bulging, they're afraid. Often if you do a Google search, you'll see the one with the kid just leaning forward and the drool rolling out. These kids are sick. This is get to the hospital right away. not only get your intubation supplies out, but also get your surgical airway supplies out. Because often, by the time these guys need an advanced airway, you're not going to be able to intubate them because their airways go on. So bad. In the ED, we always had a trach tray at the bedside. That was the first order for any rule out or actual epiglottitis. And they're sick and scary. And there's what we look like. You can see a little tight. Basically, we get significant swelling, and luckily, this one, it says during intubation. I would kind of guess that this is probably post-intubation, that they got the tube in early, and then we had the swelling around it. But what we don't want you to do, if you're not intubating, is grab a laryngoscope and say, let's just peek in there and see what's going on. That can be enough to cause just a little bit additional swelling. You lose your airway. What we don't want to do is ask the kid a lot of questions. A nice, quiet ride to the hospital. Dim the lights a little bit. Try to act like you're relaxed. Don't get the parents all worried up. When you call into the hospital, don't let the parents hear what they're saying, we have our surgical airway kit ready, and you should too. And once they're to the ED, again, shouldn't be that normal flurry of activity, everybody getting excited, because just exciting the kid can be enough to lose that airway. Opening their mouth can be enough to lose the airway. And if you do some Google images of epiglottitis, you see someone with a tongue blade. No tongue blades. No. Okay. Now this one's viral, and it's caused by many different viral illnesses, but the signs and symptoms are rapid. So in the morning they're fine. By 3 in the afternoon they might have a trach. Treated with antibiotics, O2, in that calm, dimly lit room. So we really need to try to calm down the environment as much as we can. And again, if we lose this airway, we know what's going to happen. So we really need to be ready and be diligent for someone with epiglottitis. Okay, another 7-year-old came back from the Little League World Series. Must be the place right now. Has fever, conjunctivitis, Corza, which is some kind of respiratory disorder that we don't really know how to describe just yet, and a cough. But we notice these small, red, really weird-looking spots with blue-white centers in his oral cavity. Any guesses? Again, do we need to diagnose? Treat the fever, treat the cough, treat the respiratory symptoms. This is what he looks like. So we can see the Kloppic, K-L-O-P-I-C, spots in his mouth, kind of weird-looking thing. And then he's got these weird rashes all over him. So what are you going to do for yourself? Any PPE for this guy? Yeah, you think so? I would think, yeah. Anyone know what the Kloppic signs are classic of? Measles. Geisinger Danville had 2 measles patients about a year ago, so it's still out there. Again, we had at the Little League World Series many years ago, some measles came over. Can reemerge, as we have more and more of the population not getting their vaccinations, could definitely reoccur. Viral, infection of the upper airway, droplet precautions, so mask for him, mask for us, gloves, gowns. Signs and symptoms usually about 7 to 14 days post-exposure. And with adults, just like with chickenpox, adults will pick up a pneumonia quite often. So something to think about. Again, we treat the symptoms, as we always do, and they need 4 days of isolation. So if you think about it, Little League World Series, we infect, not too many, 1,000 kids. Could that kind of overwhelm healthcare a little bit? Absolutely. Yeah, so we think about, there's a pretty big event in Philadelphia a couple weeks ago. I think I read something about that. Somebody was there, some dude. One guy visits and everybody comes. I went to Philly, not that many people came. Think about the bad guys. We were thinking 30 bombs and playing into the crowd and things like that. Just get 4 people with the measles and walk around with 1.5 million people for the day. Could be huge. Could really be huge. There's a fatality rate with measles, but it's not that high. 1 in 500. So, but then we're talking about the pediatric population. Kind of pulls on our emotions a little bit more. Okay, you get dispatched for an unknown medical. You get into the house, you see an unresponsive 5-year-old. The family's poor historians. There's a language barrier, and it's a language we don't know anything about. They report that you kind of think they're saying the child was lethargic, and they put him to bed for a nap. And that's all they said. He was sick, and he was sleepy, so he went for a nap. His neck hurt, but they said he didn't fall down or get injured lately. And he's had a fever for a day or two, and they said his fever was really high earlier today, but now his skin is cool and clammy, and this is how he presents. Now, if you remember from PALS, prior to 2005, we actually had some pretty good videos of a kid with the same phenomena. Okay, so we're up on meningitis. That's good, right? So classic meningococcal meningitis with a very high mortality rate, right? So we know as a clinician, if we see that kid, we need to hustle to the hospital. You going to wear any protection for that? Yeah, absolutely. So again, starts with flu-like symptoms, like a lot of these diseases do. Photophobia, nausea, vomiting are often seen. That stiff neck or the nuchal rigidity is a good classic sign. And again, if you have time, where have they been? Well, they've been in daycare, and like 3 of those kids got admitted to an isolation ward because something's going on, and the one kid died, but I don't know what from. Or we see meningitis in colleges often. Yes, sir.
Is purpurea usually typical of that presentation?
The purpurea or that ugly rash, not always, but with meningococcal, it often does. So we hope that we see the child before that. Usually it's just the flu-like symptoms with the nuchal rigidity. We do a spinal tap, we pick up the meningitis, and we treat them aggressively so they don't get into that really ugly rash. But we do see it, yes. If not treated effectively, because it's an infection of the meninges, we can see permanent neurological disorders. So again, life-threatening disease, highly transmissible, and can cause permanent damage. Lots of bad stuff. Okay. Signs and symptoms usually about 5 to 19 days. So if your child was in a daycare center, a school, or a college, and one kid's diagnosed with meningococcal, we're going to really be doing fever checks for about 2 weeks, 3 weeks. 10 to 15% mortality rate, and it happens quickly. So they're fine on Monday, and we're burying them on Thursday. So it's kind of scary. Okay, this is one of my favorite ones. I like this one. We talk about this one when I do my ACLS classes. 35-year-old at an outpatient surgery center developed the following symptoms 10 minutes after the induction of succinylcholine: rigid muscles, tachycardia, and a sudden fever of 104. He was afebrile when he came to the surgery center.
Malignant hypothermia.
Where are you? Excellent. Have you ever seen it?
No, I used to use socks.
Okay. Yeah, a lot of us used to use sucks. Yeah, and one of the reasons we don't like sucks is, one, it's long-acting, it's unpredictable, and it can cause malignant hyperthermia. So the key here is someone that wasn't febrile got succinylcholine administered, and now they are febrile, and often have these other symptoms with them. So anyone know the treatment for malignant hyperthermia? This runs into a problem. Most outpatient surgery centers that administer succinylcholine have what we'll call antidote, and it's dantrolene. Now, the problem with dantrolene is it's just not one injection, it's an IV drip. So when I do ACLS for these outpatient surgery centers, they say, well, yeah, we're just going to hang dantrolene, and the EMS is going to come, the paramedic's going to grab the guy, and off they go. I'm like, and who's going to run the dantrolene? Well, those paramedics, they do IVs all the time. Who here has dantrolene on your protocols? So what does that mean? You have 2 options, right? Stop the dantrolene, or tell the anesthesia guy he's coming with you. And guess what? If the anesthesia guy is coming with you, he has 2 problems. 1, he's not going to get paid because he's not going to do any more cases, and 2, he needs a lift home. So there's something that you can do in your jurisdiction. Talk to your surgery centers and see what their real thought is if they have somebody with malignant hyperthermia. Who's going to monitor the dantrolene on the way in? Because we definitely don't want to start it and then stop it if we have somebody with malignant hyperthermia. So it's better to do that now than, I know we don't do this anymore, but have a pissing match in the middle of an acute care patient, right? So what assumptions are at a surgery center are not what's real world in the back of an EMS unit. And I know that's new stuff, but sometimes it does happen. There's assumptions. So these folks are sick, and they do need the dantrolene. Fatal, can definitely be fatal. Okay. 51-year-old admitted to a rehabilitation hospital. They were a trauma alert about 5 days ago. Also have a history of pancreatic cancer. So not a lot of luck going on with this poor 52-year-old female. She began from bleeding from her incision last night. And it was just a little bit of oozing, and the nurses didn't want to call the doctor and definitely wouldn't call EMS yet because it's not a holiday. So they didn't do anything about it. But then they noticed this morning she had severe vaginal and rectal bleeding. Pardon? Yeah, I can even spell that. And you're done guessing now. Now she's vomiting blood, and you notice a significant amount of bruising all over her arms and torso, which is new. So those of you that didn't hear what we heard up front, which is a proper diagnosis, any idea what this might be? Yeah. Who said that in the back? You're done also, aren't you? So disseminated intravascular coagulation. So this is something that, fortunately, most of us only see once if we get to see it at all. Raise your hand if you saw true DIC ever. Fun stuff, right? No. Snake bite, yeah, absolutely, absolutely. Did you get to start an IV or two? IO, awesome, love IOs. So basically, what happens with DIC, a foreign toxin or product is inside the body, and the body doesn't want it. But what happens, they don't reject it, the body gets confused. So we see that with envenomations like snake bites, spider bites, with products left inside the body post-surgery, with some folks with regular diseases it can happen. So with this, the body gets confused. Oh, here we go. Trauma can cause DIC, pancreatitis can, malignancies, transfusion reactions can cause DIC, obstetric complications including HELP, retained placenta fragments, things like that, hepatic failure. Your envenomations are on here, transplant rejection, and many, many other things, including heat stroke and hyperthermia. So what happens, the body has this foreign object, and it doesn't know what it is. So it thinks, nothing else is working here, we're not going to go septic. The body decides to decide that it's a bleeding disorder, and it's really kind of complicated to understand how that happens. So this is a platelet under a microscope, and if we look at the end, those little fingerets, at the end of those platelets, it's the 2B3A glycoprotein receptor site. And that's a really big word to say, but that's what gets activated and causes platelets to join each other to form a clot. So in a normal day, the 2B3A glycoprotein receptor sites are turned off. Platelet passes another platelet, they wave to each other, off they go. If we have the activating of the clotting cascade, platelets will start to adhere to where the bleeding occurs. It'll activate the 2B3A receptor sites, and the platelets will start to join each other and form the clot. But with DIC, the body doesn't know where the bleeding is, because with a snake bite, we don't have bleeding. With retained placental products, we don't have bleeding. With pancreatitis, we don't have bleeding. So what happens, the platelets get turned on, those receptor sites are activated, and the platelets just start joining each other. And as they join each other, they're like, well, this is kind of weird. We're supposed to be at a party, and we're just holding hands and driving around the block here. So what they do when they get to a skinnier part of a blood vessel, they say, hey, I can't get through here. Now what are we going to do? Well, we're just going to hang out. So what happens with DIC, we get these micro emboli. So these little clumps of platelets just end up stuck. And when they get stuck, they actually trap all the other platelets that are trying to get through. So they actually, with DIC, what happens is we deplete our platelets. Platelets are what we need to clot. So once we deplete our platelets, we just start bleeding from everywhere. And that's why with DIC, disseminated intravascular coagulation, we have all these microclots. Anything that can bleed starts to bleed. And if you ever saw true DIC, it's bleeding from everywhere. So that's how that works. On another point, did you ever hear of Plavix? Plavix is an antiplatelet. When someone takes Plavix, Plavix actually lays on those 2B3A receptor sites and makes it that the platelets can't join together as easily. Doesn't stop it altogether, but that's how that works. So once the platelets are joined together, they actually build fibrin, and fibrin's kind of like jelly, and that's what really holds the platelets together even better. Once that happens, this is kind of what happens, and we can see just some massive bleeding, and this is just two of many, many, many photos you can pull off the internet of DIC. Of course, the one on the left is probably at autopsy, and that's not good. That's a ton of bleeding. Rectal bleeding, GI bleeding, anywhere we had an IV that we took out, bleeding, and these folks are sick. The thing with platelets, with DIC, we want to run tons of platelets, tons of blood products, but there's also a controversial thing that you might see, and that's to give them heparin. And what heparin is a blood thinner. So sorry to tell you, but grandma's bleeding out today, so we're going to give her a blood thinner. But the idea with heparin, and it's controversial, is that the heparin will break up those microvascular occlusions. take away what is the cause now of the DIC. Once we get that under control, now we have to take care of the cause of the DIC. So if it's a snake bite, we're going to amputate the arm. If it's an organ issue, we're going to remove the organ. So these folks, if they survive, are not going to have a good day because we need to first reverse the DIC, tons and tons and tons of blood products, and then we need to get the cause of the DIC and get rid of it. So it's bad. Most of the time it's quick. Do you remember with your snake bite guy, was it over a few hours? I'm sorry? So 2.5 hours after the envenomation, he was already in DIC? Yeah, that's definitely not good. Did he survive? Yeah. Lucky. He's very, very lucky. So the reversal agent for envenomations of pit viper, so like our eastern diamondbat, is cryofab, and most hospitals in our region carry cryofab, and if we need to, we can move more around. So he's lucky he survived, and not only from the DIC, but even just a single envenomation. I'm sorry? 18 units of cryofab? That's a pretty hardy dose. Usually start with 4 and just keep going till the swelling's down. Awesome. Anybody else see DIC? What was yours? GI bleed? Okay. So he probably depleted most of his platelets and then kind of just kept on going and off he went. Yeah. So 30 to 70% mortality rate. So you're the patient's family, and you say to the doctor, what's the chances of survival here? Well, 30 to 70. That's a pretty big window. But we can narrow that window down a little bit by how horrible they look. So, if he's just starting to have a little bit of rectal bleeding, different than if we're spewing blood out of everywhere. So bad phenomena. Okay, elderly female. She's hypothermic, so her temperature is below normal by about 4 degrees. And the room temperature of her house is 72. I will give you an instructor hint. She didn't wander outside in a cold day, so it's not like she was outside and came in. She's hypotensive. She's lethargic. She has generalized edema, so body swelling everywhere, dry skin, and a headache. Pardon? Any ideas? This is one that's very, very rare. You hardly ever see. Hypothyroidism. So we'll talk about a thyroid storm in some of my other lectures. When you have hyperthyroidism, this is myxedema coma or low thyroid. And the key with that is hypothermia as someone that wasn't in a cold environment. So most of us are not below 98.6 if we're healthy in a warm room. So if we get into a room that's normal temperature and somebody's cold and they're not in shock, we have to think, what's going on here? It's just due to a decreased stimulation of the thyroid, presents slowly, but sometimes can present rapidly. And if we have that rapid onset of symptoms, it's usually fatal. It can be treated with thyroid replacement products, so Synthroid and things like that. If not treated rapidly, it often is fatal, up to a 70% mortality rate. So myxedema coma or hypothyroidism. Getting toward the end already. 24-year-old, flank pain and dark urine. So what are you thinking there with flank pain and dark urine? Pardon? Kidney stone? Could definitely be. Yeah. But here's a key. Admits to using stimulants for a week. And this 24-year-old's a bodybuilder and very aggressive weightlifting. 2 sessions that were 3 hours long, just cranking it out. And then followed by 2 to 3 hours of running. He says he might have used steroids also, but most of the stimulants were just something to give him higher energy. Acute renal? Could be. Rhabdo? Who said that? Someone new? Well, 2 of you. All right, now we're tag teaming. So if we say rhabdo, can we say it's an acute renal thing? Absolutely, because they come hand in hand. So what are we calling this dark urine if we're talking about this guy blowing through a lot of muscle time and things like that? So he has myoglobinuria. So let's start in the beginning, since we already diagnosed rhabdo. We're exercising a lot, and what happens? We get some muscle breakdown when we exercise. As we break down that muscle, myoglobin is released into the bloodstream. Myoglobin can turn your blood kind of dark chocolatey colored. And I have ran long distances in the past, and I have ridden a bicycle for a pretty long period of time for the Muddy Angels. You all know the Muddy Angels, right? Please say you do. Join us sometime. It's a great organization. And actually, 2 years ago when I rode with the Muddy Angels, I had a little bit of an accident, and I knew that I was in trouble when my arm started bleeding, and it was chocolate milk. It's like, all right, so I have some muscle breakdown here. So anyway, back to this guy. So muscle breakdown, myoglobin into the bloodstream. He ends up with myoglobinuria, which is that dark urine, kind of chocolate colored. So what can happen then is we can actually start to clog up our kidneys. So after that, we run into some problems. So here's this guy's urine, and it's not from a severe urinary tract infection or a kidney stone or something like that. So once we can't filter, these kidneys start to stop working, and we can end up with rhabdomyolysis. So some of the things that could cause rhabdo: crush injuries. Oh no, what's that second one there? Laying on a hard surface for lengthy periods of time. When could that happen? OR, let's think somewhere else. Backboards, yeah, what do we know about backboards? I'm not getting into that one, that's another lecture. Pardon? Falling behind a couch. So anytime you get that on the floor for an unknown period of time, they're candidates for rhabdo, at least some myoglobinuria. So are we going to do much about that other than IV fluids? No, not really. Electrical burns, high incident of rhabdo with the electrical burns because we get significant muscle injury that we don't see. Sepsis, ultra athletes. So marathoners, usually not. So if we're talking rhabdo for a runner, it's usually past the 35 to 50 mile mark. That's when then we'll see that. But we can have that red herring that someone that doesn't exercise quite well and they do their first marathon, they could have rhabdo. Again, are we going to treat it any differently on the scene of a marathon? We're going to load them up with a couple liters of saline and get them on their way. Steroid use and statins. People that are taking statins to lower their cholesterol can actually run into rhabdo. And I put the bottom one, the Muddy Angels. Remember, we're riding our bicycles for 530 miles, so we're starting in Boston and riding to D.C. to honor fallen EMS professionals. So if Muddy Angels comes through your area and one of us are peeing dark-colored urine or you start an IV and it comes out chocolate milk, give us an extra liter of saline. If you don't know anything about the Muddy Angels or the National EMS Memorial Bicycle Ride, stop by our booth anytime the next 2 days. We'll tell you about that a little bit. It looks like this year we're going to try to shoot through Philadelphia in the lower area of this region. We don't know for sure yet. And I think 4 years ago we came through. It's a great organization. So anyway, back to rhabdo. Quick commercial break. Could cause renal failure. Most of the time it does. Electrolyte disorders, cardiac dysrhythmias, and oh my gosh, look at that one. That's a disease we heard. DIC, because we have all this free-flowing myoglobin, can actually start to cause some vascular occlusions and again trap those platelets and cause problems, and can also cause compartment syndrome, which we know any round area of our body can actually have enough edema that our skin becomes a tourniquet, and then we have compartment syndrome. So with rhabdo, we can also have some other things. If you ever have somebody that admitted to using ecstasy and they were dancing all night at a rave, high incidence of myoglobinuria and rhabdo for folks using ecstasy. Another thing with ecstasy, usually don't see them while they're on it, but one of the big when you come off of ecstasy is severe depression and again, myoglobinuria and jaw clenching. So with ecstasy, that's some of the things you want to look for. Fluids, you're not going to get bicarb. We're going to wait till we see a blood gas analysis for the bicarb. Diuretics and dialysis, so they might actually end up on dialysis to clear this myoglobin out of their bloodstream and see if we can recover the kidneys. And because we can have chronic renal damage, as we learned from the front row, this could absolutely be a full-time disease. I think we have 3 more to go. 26-year-old construction worker with a minor puncture wound and abrasion of his leg. His leg started to feel tight yesterday, and it's a 10-10 pain, but when you look at him, it doesn't really look like it should hurt that much. You notice some ulcers and black spots on his leg also. He's feeling tired and nauseated, and he has a little bit of a fever. Well, that's kind of atypical, isn't it? Any guesses on this one? Neck. Okay, so neck is not good. So basically with neck, your body gets mad at your body and we just start eating our tissue. So flesh-eating disease, you know, and when I was in St. Joe's ER, we sent at least in 3 years 4 patients with necrotizing fasciitis to Lehigh Valley. So neck is kind of nasty, and you know, once you lose that skin, it's just not a pretty thing. So it's bacterial, toxins. So with this guy, he actually had a toxin from the soil at the construction site injected into his body, and he developed necrotizing fasciitis. Causes tissue hypoxia and then tissue death. So it dissolves the connective tissue, and it looks pretty nasty. So we don't want neck. So again, the media will call it the flesh-eating disease. Occurs rapidly. So these folks could actually be injured in the morning, and by that evening start to show signs and symptoms of neck, or within 24 hours, and it's bad. Again, IV fluids, antibiotics, and quickly removing that dead or dying tissue so it doesn't continue on. A lot of facilities are using hyperbaric medicine to help reduce the mortality, and it can reduce it by about 20%. Can be fatal in a short period of time because these folks will become septic. Of course, they'll be shocky. So, you kind of almost treat it like you would a burn. So we have a couple little closeouts, and then we're going to get you guys out of here, I think, just a little bit early. The thumb. That's a typical lesion that we'll see with rabbit fever or tularemia. And after 2001, the CDC was pushing awareness of rabbit fever or tularemia pretty heavily as a weapon of mass destruction. I haven't seen any literature since then that there's been increases of tularemia. But again, would you be running this guy lights and sirens to the hospital with a little lesion on his thumb? No, not at all. How about the second guy over with his mouth open with those little pimples? What is that? Pardon? It looks
It looks bad, I would rush.
You would rush, okay. So if we have one person with that second one in with that disease, it's a worldwide event. And yeah, so we held our breath, and we have about a day or two left, and we can say that smallpox was not disseminated at the Popal visit in Washington, New York, or Philadelphia. What the bad guys could have done is infected one bad guy with smallpox. And if their timing would have been just right, what happens with smallpox? Guess what the initial symptoms are? Fever, cough, lethargy, typical flu-like symptoms. So with smallpox, you have the flu-like symptoms, but then it gets even worse. You feel like the worst flu ever. So about 7 days of flu-like symptoms. About day 7, you start to feel better. We call that the prodromal period. You call work and say, hey, I'm starting to kick this. I think in a couple days I'm going to be in. That's the best you're going to feel for a long time. Once that 2 to 3 day prodromal period goes over with, now the virus starts to load and shed. So what they'll start with, and you can see it on his tongue a little bit, you're going to get the smallpox lesions on your tongue first. Every time you exhale, about 1 million smallpox particles go into the air. Smallpox is hardy. If I had smallpox, they would dance in this room till the conference was over on Friday. So there's documented cases when smallpox was a prevalent disease before 1979 of a person going into an office building, asking for directions, and leaving, actually spread smallpox within all 5 floors of the office building. So if the bad guys had smallpox, which we thought they did because in 79, smallpox was totally eradicated from the world, Russia and the United States decided to keep some samples for scientific testing and for antibiotic and for vaccine purposes. Now, of course, that scientific study could mean whatever it means, but what happened during the Reagan era with the Russians? They sort of fell apart, didn't they? So BioRepair is where they kept the smallpox lesions in Russia, and when it was time to get all those samples disseminated to a more safer location, Russia said, somebody didn't sign all these out. I don't know where they are. So Russia lost, and they are not accountable for all their smallpox particles. So it was really thought that they sold them off. Well, I can tell you we had enough worldwide events now that if the bad guys had smallpox, they dropped it on the floor and lost it or something like that, because the Popal visit would have been perfect. Get one guy with that rash on his tongue and just walk through the crowd, hey, how you doing? It would have been a worldwide event within 2 weeks. And it's not, so that's a good thing. With smallpox, breathing, highly contagious. Touching the lesion, highly contagious. And these folks are in a lot of pain. When we develop the smallpox pustule, it splits the dermis from the epidermis, 2 layers of skin, so it hurts really bad. In your mouth, in your throat, on your eyes. So a lot of survivors of smallpox also were blinded. So in a lot of pain, a lot of folks get septic, and they're really bad. Good thing for you, good take home. If smallpox does come back, which there's no smallpox anywhere in the world, you have 4 days to be vaccinated, and you should be covered, and you shouldn't get smallpox. So keep that in mind, and I would hope that we'll take care of our providers first and not the general public if we have a smallpox event, but I think we're okay. How about this girl? She's got a weird thing on her neck there. I don't know what's going on with her. What do you think that is? Yummy. It is yummy. Well, did you ever see a kid run down the sidewalk and fall and scrape his knee? What do we call that? Oh, you got a boo-boo on your knee? Well, in the old days, we called it a bubo. And with this disease, we can see buboes, or we can see things that are a little bit worse.
Bubonic plague.
Yeah, bubonic plague, meaning you have a bubo. So with bubonic plague, it's a vector-borne disease. You were bitten by a flea that had the plague, and you develop bubonic plague. You get a big lump on your lymph nodes, and you look kind of silly. So that's how the boo-boo, when somebody falls, how that word came about. So with bubonic plague, lymph nodes, oral antibiotics, less than a 10% death rate, not infectious. Now, there's other kinds of plague, though. There's pneumonic plague. That's when it's in your lungs. You're a lot more sick, a higher death rate, and again, that is somewhat transmissible. And then we have what we call black plague or septicemic plague, when their digits get those microembolism. And are we on time? What time is it? What time are we done? 12:30? All right, we're almost done then. And their digits fall off, and that's septicemic plague, not good. That's septicemic plague here. Now, in the 1800s, millions of people died of septicemic plague. So we wrote a song for them. And does anybody know the plague song? It's a great song. Do you think that smells good or smells bad? It smells terrible. So if I had that, I wouldn't go to the hospital. You didn't go to the hospital in the 1800s just because your fingers are falling off. So I put some flowers in my pocket, right? So ring around the posy. You know, I got a bubo. Ring around the rosy. I have a bubo. Pocket full of posies. So I have these flowers so my fingers don't stink. What color are my fingers? Ashes, ashes. And what's going to happen to me? Oh, stick with me. I know so much useless crap, I can impress you forever. One more. Cutaneous anthrax. So anthrax is a naturally occurring illness of animals with hooves in anthrax-infected areas like Peru, the Mideast. Anthrax grows as a spore into the vegetation. The animals with hooves eat the anthrax. We shear the wool or play with the hides. We get an anthrax lesion. Over there, they don't call the media. They give you a dose of doxycycline. You don't tell anybody. It goes away. You're fine. Here in America, we make a big deal out of it, and everybody goes crazy. If it's naturally occurring anthrax, you can touch it. You can rub it. I wouldn't kiss it, but it's not infectious. You give them oral antibiotics. They all get better. Now, if we say, what's going on with this? Well, I opened this envelope and it had white powder in it, so I rubbed it on my arm for a little while and didn't take a shower, and now I have this. Then we have to think a terroristic event. But anthrax does occur naturally, so we should keep that in mind. All right, we went 4 minutes over. Sorry. Any questions? Thanks, everybody.